Right at 11 o'clock. Thank you all for joining in. I know others will trickle in as well. Please feel free to text to sign in. The code is crisis, and I'll get started. All right, so today I'll be presenting my grow presentation on the unsung crisis, as I deem it, otherwise known as sickle cell disease. So I'll be presenting sickle cell disease management overview, and we'll tie in a few concepts related to disease state and also management and care itself. A few objectives from today that I want to make sure that I'm able to communicate. Number one, discuss sickle cell disease pathophysiology and clinical manifestations. Number two, summarize key recommendations for preventative and therapeutic measures in sickle cell disease. Number three, evaluate future directives in sickle cell disease management. And then lastly, closing out with analyzing health disparities in this realm pertaining to sickle cell disease management holistically. All right, so diving right into the pathogenesis and understanding the science behind the disease state itself, just a little background on sickle cell disease. It is a group of inherited red blood cell disorders. So in sickle cell disease, your red cells become hard and sticky, and they tend to take on the shape of a C-shaped farm tool, otherwise known as a sickle. And as far as epidemiology is concerned, sickle cell disease is an international disease, uh, stemmed from Africa, multiple spots in Africa, but currently there are 2 million Americans which are carriers of the sickle cell gene. 100,000 Americans living with sickle cell disease currently, and then there are 2,000 plus cases of sickle cell disease identified through routine neonatal care screenings, where much and many of the diagnosis is found. High level pathophysiology of the disease state itself. The phenotype of sickle cell disease generally is triggered by the polymerization of deoxyhemoglobin S. So, hemoglobin S is the hallmark of sickle cell disease, and when hemoglobin S is deoxygenated, there's a replacement of glutamic acid with valine at the B6 position, which results in hydrophobic interaction with other hemoglobin molecules. And so here you'll see this is just a depiction of that itself. The small red circles represent the oxygen that is released from oxyhemoglobin, and then they are then deoxygenated, where you'll see the purple circles. And upon the deoxygenation, you'll find that replacement of glutamic acid or valine in replacement of the glutamic acid, which is normally seen. And from there, you'll find that there's an agglutination or aggregation of these deoxygenated red blood cells, which polymerize and they form fibers, which align and begin to distort the cell shape. And that's where you'll find that sickle cell shape that I alluded to earlier, and the sickling of these hemoglobin S cells and molecules. So ultimately, what this amounts to, or what it manifests in our patient populations, it leads to that sickling I alluded to, but it also can cause vaso-occlusion. It can cause hemolytic anemia, ischemia, reperfusion, injury, and inflammation across various sites, various organs in the body. And so, clinically, this manifests most often as acute painful episodes, otherwise known as crisis, for our patients, with other acute and chronic complications along the way. And I think this graphic here also depicts uh, pretty clearly what the difference is between normal red blood cells and abnormal sickled red blood cells looks like. Other clinical manifestations in sickle cell disease, generally there's a high degree of heterogeneity among similar patients. So sickle cell disease can look different or widely different amongst similar patients or seemingly similar patients. And so there's also a variable occurrence of vaso-occlusion, hemolysis, and other chronic complications due to the effects of, modulatory genes which can control hemoglobin F. Hemoglobin F in the realm of sickle cell disease is a positive. It's normally seen amongst infants and pediatric populations, and it has been seen with higher levels of hemoglobin F. Sickle cell disease is a much more manageable disease state. In reference to genotype association with clinical symptoms seen in sickle cell disease, generally these individuals, or generally individuals with sickle cell anemia, who present as homozygous for this hemoglobin S cell type, and also patients with the sickle cell beta thalassemia have more severe manifestation than those who have the heterozygous hemoglobin SC cell type or the sickle cell beta positive thalassemia. Thalassemia is also noted to be something that prevents the formation or helps to prevent the formation of red blood cells. So it can uh, attribute to anemia seen in this patient population. So acute complications, this is a list, it's not an exhaustive list of all acute complications, but these are commonly noted in sickle cell disease patients. You can see vaso-occlusive pain, as I alluded to earlier. Strokes are commonly seen in these patients. Acute chest syndrome, which is really a culmination of uh, all morbidities that would culminate in chest pain or acute chest pain. So this can be pulmonary, it can be occlusive. Renal infarcts, medication toxicity, bone infarctions, myocardial infarctions, complications related to pregnancy, priapism, and also venous thromboembolism. So these are all acute complications that can manifest from the sickle cell disease state itself, and something that we triage here at UW Health pretty commonly as well. And in addition to the acute complications that I noted, uh, these are also some chronic complications that are commonly seen here that we treat at UW Health, but also at other institutions as well. So patients will commonly present with pain, anemia, neurologic deficits, pulmonary conditions, renal impairment, hypertension, osteoporosis, cardiomyopathy, uh, hepatotoxicity, leg ulcers, proliferative retinopathy. Once again, this is not an exhaustive list, but these are a good amount of complications that can present in our patients who are admitted here at UW Health, which we care for. So I'll take a brief pause here with an engagement question. And I'd like to ask of you, which of the following is not a common complication of sickle cell disease based off of what has been discussed so far? Feel free to put your answers in the chat box. All right, so I see a good amount of B's. Yes, so thank you all for paying attention and listening to me today. Yes, elevated INR is not a noted common complication of sickle cell disease, although it may be attributed to other comorbid factors in these patients who are treated inpatient. So diving into preventative measures of sickle cell disease, generally when we think preventative measures in this patient population, there are two uh, noted routes that we can go. And so the two major measures for preventing infection in individuals with sickle cell disease be one, penicillin prophylaxis, and then two, immunizations. And so I'll talk a little bit about both. Starting off with penicillin prophylaxis, we have here the PROPS trial, which is a trial where children under 3 years of age were randomized into two groups, either a penicillin PenVK group, 125 milligrams by mouth twice a day, or a placebo. And in the conduction of this PROPS trial, it was halted after 15 months as it was a significant a notation at 84%. It was an 84% reduction in pneumococcal disease in this patient population, which was enough to deem that penicillin prophylaxis was effective in this regard. And so there was a second study or a study two follow up for this trial where really the primary endpoint was comparing incidence of bacteremia in patients on prophylaxis versus those who had discontinued prophylaxis at 5 years. And so in this study, 6 children had a systemic infection caused by strep, 4 in the placebo group and 2 in the continued penicillin group. And what this really told us was, children with sickle cell anemia who have had prior severe pneumococcal infection or splenectomy for receiving comprehensive care, they should safely stop prophylactic penicillin therapy at 5 years of age, in contrast to continuing prophylactic penicillin. Some alternatives also noted to PenVK for this patient population, benzathine penicillin, in regards to the compliance concerns that may be seen, and then also macrolides for those who may have a penicillin allergy. Now, also in sickle cell disease or with diseases like sickle cell, researchers believe that the entrapment of red blood cells in the spleen, followed by splenic infarction, leads to hyposplenism. And so, this hyposplenism eventually proceeds to be functional asplenism. And that's where you have here the functional asplenia in sickle cell disease patients, where these patients are highly susceptible to bacterial and viral infections, largely due to that functional asplenia that develops early in childhood. And so this asplenia can increase the risk of infection with encapsulated bacteria, including strep, flu, and also meningitis. And so, with that being said, some of the recommended vaccinations for asplenia patients or asplenia noted in sickle cell disease patients would include these series here. So vaccines, of course, as we know, are a great way to prevent many serious infections. And children and adults with sickle cell disease should get all recommended vaccinations, including the flu vaccination. So people with sickle cell disease are considered high risk for certain infections and should follow a special vaccination schedule for the flu vaccines, pneumococcal and meningitis or meningococcal vaccines noted here. So that's the hallmarks for preventative therapy. I also wanted to provide here, hydroxyurea, excuse me, which is a widely known in this space as a pillar of sickle cell disease treatment. And so here in this case, hydroxyurea is also used for the prevention of vaso-occlusive events and complications. So in regards to hydroxyurea, it was first approved for treatment of adults with sickle cell disease in 1998. So um, I believe at that time I might have been 3 years old, might much before I was introduced to pharmacy. But uh, after the FDA approval for the use in adults, there was an increased efforts, or there were increased efforts to solidify or establish the safety and efficacy data in our pediatric patients. And so, as you see here, there were three pivotal, um, pretty impactful studies that were done in the pediatric populations: the Hug Kids study, HuSoft, and also the Baby Hug study. And so, in the Hug Kids study, it was done on children or included children from the ages of 5 to 15 years old, started at a 15 mg per kg per day and escalated to 30 mg per kg per dose, unless toxicity was observed or demonstrated. And so this is a phase 1/2 trial to show that hydroxyurea was safe for kids with sickle cell disease, when therapy was directed by a pediatric hematologist. The HuSoft trial noted here, there was a slight difference as the dosing here was 20 mg per kg per dose, and it was escalated to 30 mg per kg in a follow-up study to help determine the implications of that dose escalation. But the Husol study also demonstrated short-term feasibility of hydroxyurea administration and established noted toxicities, hematologic effects, and also the effect on spleen function within infants and sickle cell disease. And then the baby hug study here was a phase three multi-center randomized double-blind placebo-controlled study um, amongst infants that were 9 to 18 months of age. And what this study provided was safety and efficacy information for clinicians considering hydroxyurea therapy for very young children with sickle cell disease. And so, um, pretty recently, it was hydroxyurea was approved to reduce the frequency of painful crisis, the need for blood transfusions in pediatric patients equal to or greater than 2 years of age with sickle cell anemia with recurrent moderate to severe painful crisis. Now, understanding, I guess, the mechanism of action or how hydroxyurea demonstrates its effects in our sickle cell disease population, um, I think noting these four categories here that we have is really the main points considering its mechanism in sickle cell disease. Now, you might see hydroxyurea um, in the oncology space as it is an anti-metabolite. So you'll commonly see it with chronic myeloid leukemia and also head and neck cancer. But specifically with sickle cell disease, the two main pathways or effects is that it has vascular effects and also the red blood cell effects. So it increases the red blood cell hemoglobin F levels, which is a positive for our sickle cell disease patients. Increases the red blood cell water content, increases deformability of these sickle cells, and it also alters the adhesion of red blood cells to the endothelium, all which constitute positive outcomes for our patients in this setting. Now, also, I mentioned it was the mainstay of sickle cell disease management, but it also reduces the likelihood of other things. I mentioned vaso-occlusive pain episodes earlier, but also reduces notable complications such as acute chest syndrome, strokes, and hospitalization rates. So something to consider as we work up and treat our patients here. Hydroxyurea is noted to be the mainstay of therapy in our patient population. Now, diving into chronic management, which is what we'll commonly see patients admitted to UW for, they might have acute complications, and then they're also on chronic management. So, considerations for chronic management therapy selection in our sickle cell disease patients, we want to make sure we're considering the age of our patients, the route of administration, uh, frequency of lab monitoring, and also toxicity concerns, as many of the medications do require monitoring and also may constitute toxicity. So understanding this from a holistic level will help us to improve the care that we can provide. So diving into the disease modifying therapies for sickle cell disease, I think it's important to provide a small caveat here that these medications are intended to be started when the individual is well. So there's a difference between acute management and chronic management. And so the FDA approved medications that I'll touch on in a few are really only designed for uh, starting or initiation when the individual is now. It's not necessarily for um, the appropriate treatment of acute pain. So I mentioned hydroxyurea earlier. This is a small chart of a good amount of information on hydroxyurea. It was FDA approved in '98, as I alluded to, and you'll normally find between adults and peds patients both started or initiated on this therapy. Adults commonly started at 15 mg per kg once daily regimen, and then for peds, 20 mg per kg per dose once daily regimen, both noted to have a 35 mg per kg per day max dosing. And so, also what you'll notice is there's a titration. So you'll have to titrate these medications based off of, if there have been pain episodes or uh, titrating per tolerability. And so we'd want to monitor blood counts every 2 weeks. And if blood counts are in an acceptable range, there may be an increase by 5 mg per kg per day. And this in an adult population, there can be a 5 mg per kg per day increase every 12 weeks until the max tolerated dose. And then for our peds population, there may be an increase of 5 mg per kg per day every 8 weeks until mild myelosuppression is achieved, or if there is a painful crisis that has been noted. Some other benefits to hydroxyurea, uh, some of the outcomes that were noted here, which were noted in some of the trials I alluded to earlier, and then some caveats, right? Hair loss, some GI symptoms, and then we generally, recommend the avoidance of this medication prior to conception and during pregnancy for our patients. Second medication I wanted to touch on is L-glutamine, so brand name Andari. This was FDA approved in 2017. And so this is a medication that is for patients who are 5 years and older. So it's a oral medication. It comes in a powder that can be added to food or beverages. And so this is dosed on a stratified weight-based scale. So patients who are less than 30 kgs will get a 5 gram twice daily regimen. And between 30 to 65 kg, they will get 10 grams twice daily. And then if you're greater than 65 kgs, you would get 15 grams twice daily, noting the total dose per day as well. A pro here with L-glutamine in contrast to hydroxyurea, there is uh, no lab monitoring or no common lab monitoring, and this can be taken in addition to hydroxyurea. So hydroxyurea being the mainstay of therapy, and this can also be added on in addition. One con that I would note with L-glutamine is that the long-term data is lacking that hydroxyurea does have. So the monitoring or continual or perpetual monitoring of long-term clinical data for patients who are treated with L-glutamine is still in progress. Caveats that I've noted is, the use of pharmacologic grade L-glutamine is recommended and not necessarily the over-the-counter product. And then also monitoring the GI symptoms as well for patients who are treated with L-glutamine. I mentioned this is the second FDA approved drug, which was in 2017, and it also comes with a pretty hefty price as initial cost at drug release was $40,515 per patient, something to consider. So we also work up where we're discussing um, different therapies for sickle cell disease. This tends to take the oxidative injury pathway, which um, is in reference to its increase in NAD. So NAD is nicotinamide adenine dinucleotide, and glutamine. What that does is it increases the NAD redox potential, and so what happens is that um, NAD will end up being reduced, and our sickled red blood cells will be oxygenated, which will combat the deoxygenation you'll see of the hemoglobin S red blood cells, which would also prevent the sickling, the polymerization, and things like that from happening. Third medication I wanted to briefly touch on here is voxelotor, and this is also something I've seen uh, a few times staffing here at UW Health amongst our medicine and surgery patients. This is a med that is approved for patients of 4 years and older. It's an oral tablet, can also be an oral suspension for our pediatric patients. This is also a stratified weight-based scale of dosing where you'll see um, generally a 1.5 gram once daily dose for adults and pediatrics above or equal to the age of 12. And then for our pediatric patients less than 12, between 4 and less than 12, you'll have either 600 milligram once daily, 900 milligram once daily, or 1.5 gram once daily, depending on your weight. Once again, similar to some of the other medications noted, um, lab monitoring or monitoring in general, it's minimal in comparison to hydroxyurea, although you do have to monitor for dose adjustments and considerations for CYP interactions that you might see amongst other medications. This is also a medication that can be taken in combination with hydroxyurea, and some other benefits: it increases hemoglobin levels, decreases hemolysis, improve just global functioning from a high level perspective, and it may also improve fatigue. And so, thinking of voxelotor from a science or a mechanistic level, it's a polymerization inhibitor. And so, what this does is voxelotor, it reversibly binds to hemoglobin and um, stabilize it in its oxygenated state. So it stabilizes the hemoglobin before it loses or is deoxygenated, where you'll then see the sickling of red blood cells. And then fourth here, I wanted to note crizanlizumab, brand name Adakveo. And so this is a monoclonal antibody which was approved in 2019 for patients that are 16 years of age and older. And so this, in contrast to the others, is an IV formulation, and uh, this can reduce acute pain episodes. It also can be combined with hydroxyurea therapy, and it's a good choice for severe and frequent pain episodes that you might see in a certain pain patient population. So I mentioned the IV access that has to be deemed appropriate for hospital infusions. Some other things to consider: arthralgias, back pain, nausea, and it also may cause platelet clumping in samples that have been collected in EDTA. So generally, patients are dosed on a 5 mg per kg regimen, and this is one dose on week 0, one dose week 2, and then from then on would be every 4 weeks, 5 mg per kg. So I noted the oxidative injury pathway for glutamine and also for voxelotor, but for crizanlizumab, this is more so focusing on the adhesion, right? So this is a monoclonal antibody which binds to p-selectin, and it inhibits interactions between endothelial cells, platelets, red blood cells, and leukocytes. And so the translocation of p-selectin, I mentioned that um, the translocation of p-selectin to the activated endothelial cell surface, it results in adhesion of these um, sickle erythrocytes, and so to bind to p-selectin and inhibit that is preventing that adhesive property that is seen in sickle cell disease patients. So I noted here the SUSTAIN trial, which helped to establish the clinical outcomes and establish some of these rates, right? Annual rate of sickle cell related pain crisis, median time to first crisis, and most common adverse events here. All were deemed to be positive, in contrast to placebo, which is where the efficacy and safety data came from, primarily from the SUSTAIN trial, which helped to get or garner the FDA approval of crizanlizumab. Now, in comparison of novel therapies, between glutamine, crizanlizumab, and voxelotor. Uh, this is a chart I put together just to combine some of the details in which I've spoken on over the last few slides. All three medications have a place in therapy, and one may be more recommended over the other depending on the different patient case or different scenarios in which a patient may have been treated with one or both of these medications before in combination with hydroxyurea. But it is important to note that these agents aren't included in guidelines at this point, although they are FDA approved. And so you'll commonly see these medications in conjunction with hydroxyurea. Uh, but data on these medications and the clinical use of these medications is still being collected for sure. So I mentioned these novel targeted pathways. This is generally where drug manufacturers in the sickle cell disease space, when they're talking about research design, they're designing medications that can attack sickle cell from one of these pathways I mentioned earlier: crizanlizumab, glutamine, and voxelotor. You'll see here oxidative injury and adhesion was addressed, but there are a few other pathways that can be addressed with our research efforts moving forward. So this, I'll begin to talk on the management of sickle cell disease, and or acute complications that may arise from our sickle cell disease patient population, and management looks a little different. And so, starting off, number one, I wanted to touch on just important considerations and a stepwise approach for caring for patients who present an acute pain crisis. And so, number one, we would have to triage rapidly, right? So, triage the patient rapidly, and this is done within 15 minutes. The individual likely has been having a pain at home that has exceeded what they can manage with oral opioids, and so considering that, we would have to step up our pain therapy, step up our pain directives, and then we also want to follow individualized care plans if available. Sometimes they are, sometimes they're not, but it is important to note these things as it can help to get us to concise therapeutic plan in a timely manner. Number two, we want to assess pain clinically, and what this means is we need to actually believe the patients, believe the individuals and their families' self-reported pain. Pain is hard to quantify. It's hard to quantify objectively, and in these cases, in pain crisis, it's important to take that in consideration. We want to rapidly assess pain locations, quality, duration, and severity, assess potential comorbidities that can cause pain. So this can be the necrosis of a joint, compression fracture, etc. And then also assess potential comorbidities that require other treatments like stroke, infections, acute chest syndrome, and splenic sequestration. And then lastly, number three, initiate analgesia as soon as possible. And so this is recommended to be done within 30 minutes or in less than 30 minutes. Most individuals with sickle cell disease require opioids, and the initial dose is based on intensity of pain and previous effective doses, which alludes to the care plan that you'd want to acquire upon admission or upon presentation to the ED. But if the initial dose is unknown, you want to use one of the following regimens where you have IV morphine, intravenous hydromorphone, and also intranasal fentanyl. Important distinction between intranasal here because this is what has been studied in acute pain crisis for our sickle cell disease patient population. In addition, some caveats to consider upon initiation of analgesia. Uh, we want to rapidly assess for the efficacy and repeat doses if needed at appropriate intervals. So 20 minutes for morphine, 5 to 10 for hydromorphone. We want to provide adjunctive therapies if appropriate. Avoid the ineffective therapies, and I'll allude to that on the next couple of slides. Admit to the hospital if pain control is inadequate with 3 or more doses of an opioid analgesic, and then plan for around the clock analgesia with additional doses for breakthrough pain. So, the key takeaway here is that we're not relying exclusively on PRN dosing, but we would absolutely need scheduled dosing for these patients as well. And then PRN dosing would be an adjunct. So, alluding to adjunctive therapy here, um, adjunctive therapies, as I mentioned, are in addition to and not instead of analgesia. And so, we would also want to ensure adequate hydration. So, encouraging oral fluids, giving IV fluids if hypovolemic. We want to keep the family involved. So, enlisting family and other psychosocial supports, using heat packs if helpful. Possible use of ketamine, limited data here, but uh, guidelines do recommend the possible use of ketamine if deemed appropriate, and then also treating insomnia and other conditions that interfere with adequate sleep. So therapies to avoid or use sparingly. We never want to use placebo. We want to avoid ice and cold compresses. By all means, avoid meperidine, avoiding ketorolac in adults, specifically due to its inhibitory effect on prostaglandin mediated vasodilation. The use of anxiolytics only if indicated for anxiety, not for pain. So we want to make sure we're keeping that in mind. We want to avoid the use of NSAIDs and use them cautiously if needed, as they may cause renal failure or other bleeding disorders. Using oxygen, only for hypoxia, not necessarily for routine pain. And then we want to use transfusion only for indicated complications and not for uncomplicated vaso-occlusive pain. So mentioning the novel targeted pathways, as I alluded to earlier, there are two molecules, rivipansel sodium and GMI 1687. I wanted to briefly touch on as well that have been studied as well. And so rivipansel sodium and GMI 1687 share a similar mechanism of action where both are inhibitors or potent inhibitors or potent antagonists of E-selectin. And E-selectin is noted to be expressed on endothelium cells. And what this does, it results in neutrophil capture and triggers MAC1 activation, which allows for red blood cell capture. And so preventing E-selectin, it prevents interaction between leukocytes and vascular endothelium, and it increases blood flow by reducing cell-to-cell aggregates and vascular occlusion in sickle cell disease. These are noted trials, and this is early data for rivipansel sodium, where the loading dose is 20 mg per kg, followed by 10 mg per kg IV every 12 hours, up to 14 doses. Uh, Commonality amongst the three trials included here is that time to vaso-occlusion resolution was decreased, time to transition to oral opioids was decreased, and then time to discharge was also decreased, which may have one wonder why, these might be viable therapy options, but it is important to note that rivipansel sodium was discontinued, or the trials were discontinued, and the development of this medication was discontinued in early 2021 as rivipansel sodium failed to meet primary or key secondary efficacy endpoints. And so the primary endpoint in this case was time to readiness for discharge, and key secondary efficacy endpoints were time to discharge, cumulative IV opioid consumption, and time to discontinuation of IV opioids. So this was a pretty big blow in the sickle cell community, as this is thought to be one of the next groundbreaking therapies. But pending the discontinuation of rivipansel sodium, glycomimetics is transitioning to focus on the development of GMI 1687. As I alluded to earlier, they share a similar mechanism of action. GMI 1687 is a small molecule, and it's due um, to its potential for subcutaneous administration in an outpatient setting. So trials are expected in 2022 of this year. And so further updates on GMI 1687 are pending. All right, so I'll take another brief pause for our second engagement question here. Currently, there are only 5 FDA-approved medications for sickle cell disease, and this is also just to check in and make sure you all are still with me. A for true, B for false. Feel free to put your answers in the chat box. All right, so thank you to the brave souls that have answered. Um, the correct answer here is false. So thank you for the effort. I really appreciate it, but there are only 4 FDA-approved medications for sickle cell disease. Want to make sure I keep everybody on their toes here. Uh, but this is also room for improvement, right? Uh, Directives for future research. We have 4 FDA-approved medication in this space, and considering our patient population, one could argue that it's not enough. So, touching on curative therapies as we begin to wrap up here, um, in reference to curative therapies, we're thinking hematopoietic stem cell transplants and also gene therapy. And so I'll touch on both pretty briefly. In reference to our hematopoietic stem cell transplants, the American Society of Hematology, they came up with a compilation of 9 key recommendations in their 2021 guideline update for sickle cell disease management, and additionally formulated best practice statements for clinicians noted here on this slide. And so some key takeaways from these best practice statements for the hematopoietic stem cell transplants that are seen in sickle cell disease patients, um, the American Society of Hematology, they want to promote collaboration between specialists. So this can be stem cell transplant specialists and hematologists, the inclusion of patients and family in decision making, promoting heavier consideration of health literacy in regards to the transplants and the procedure itself, and then generally promoting holistic care for patients instead of uh, just or merely procedural care for patients. So these best practice statements are meant for our clinicians across the country to help improve the care for our patients and improve clinical outcomes regarding hematopoietic stem cell transplants. So, what is next in the realm or space of allogenic stem cell transplants? The next thing is haploidentical stem cell transplants. So, haploidentical stands for half matched or partially matched transplants. And so, this is something in which a donor could be a half match for a patient. And so, haploidentical related donors are a promising donor pool because they potentially extend the stem cell transplant uh, patient population as a curative treatment option to a larger group of benefiting patients. And this is just showing data from 149 haploidentical adult and pediatric hematopoietic stem cell transplants pooled for recent meta analysis across 14 studies where you see the safety data here for graft failure, acute graft versus host disease, chronic graft versus host disease, and also overall survival, where you see here overall survival was 91%. So this is, uh, in the eyes of many clinicians and researchers, the next step in stem cell transplants for curative therapies. Some other things to consider are supportive care considerations, right? Iron overload, seizure prophylaxis, neutropenic fever, and also considering infertility for patients who are looking to get pregnant in the future. So moving forward in the realm of stem cell transplants, you want to consider a longitudinal registry, increase access to care for our sickle cell disease patients with specialists, enhanced evaluations process. There's an immense need for predictive biomarkers, which can help to objectify clinical outcomes in the space, and then also updated data needs to evaluate newer alternative donor transplantation regimens. Regarding gene therapy in the setting of sickle cell disease, it's to introduce a new gene or edit a sequence of genes to have the potential to cure sickle cell disease. So unlike stem cell transplants, these approaches modify the person's own stem cells, and concerns about graft versus host disease don't apply. Typically, what you'll see is these stem cells are harvested, manipulated, and reinfused as part of an autologous hematopoietic stem cell transplant. So, in regards to gene therapy mechanisms, it's generally regarding one of these three, providing a corrected beta globin gene, providing a modified beta globin gene that has corrective properties, and then also um, promoting the upregulation of hemoglobin F. And so, in reference to our beta globin gene correction, the reversion to the wild type sequence at one or both alleles of the beta globin gene, the locus could convert sickle cell disease to either of the following, whether a sickle cell trait, benign carrier condition, or a normal adult hemoglobin A. And the graphic here is really just depicting the process where you'll have blood forming stem cells collected, um, harvested, modified, and then transplanted back into the patient. Number two, regarding the anti-sickling beta globin gene, this is the corrected or modified gene where there's a substitution between glutamine for threonine at the position 87. And what this does, this amino acid switch replicates the region of the gamma globin sequence that is thought to block polymerization of sickle cell hemoglobin in the red blood cells. So this is the modified uh, therapeutic pathway. And then thirdly, we have the gamma globin upregulation via the targeted BCL11A gene. And so this BCL11A gene, it helps to facilitate the process of the switch from gamma globin to beta globin. And what happens when you have that switch from gamma globin to beta globin, you are minimizing or reducing your production of hemoglobin F. And hemoglobin F in this patient population, once again, is attributed or associated with positive clinical outcomes. So we want to be able to increase hemoglobin F production if possible. And so there have been genetic manipulations to target specifically and block the BCL11A gene, which would reverse the switch and can drastically increase the levels of hemoglobin F. And so, genetic mutations or manipulations in this setting pose significant potential to increase clinical outcomes in our patients, as we see thus far in sickle cell disease management. Now, I also wanted to close out. I mentioned earlier about just disparities in sickle cell disease treatment. I wanted to close out with a brief segment on healthcare disparities in sickle cell disease. So, um, starting off with a brief engagement question as well. This is not a trick question like the last one, but sickle cell disease can manifest in which of the following races? Once again, feel free to drop your answers in the chat box here. All right, I'm seeing a lot of D's come through. So we have learned a lot in pharmacy school. Most times when you see D, all of the above, it is the correct answer. So yes, all of the above. It can occur in and manifest in all of these races, though sickle cell disease predominantly is seen in Black and African American patients. So, touching on sickle cell disease in our minority populations, it can occur in one out of every 365 Black or African American births. It also is seen in Hispanic Americans at a 1 in 1,600 rate. And then uh, in Black or African American babies, about 1 in 13 are carriers of the sickle cell trait itself. And so when we think disparities, this graphic here, it really highlights the the difference between the number of estimated persons with sickle cell disease in the US versus the number of sickle cell disease treatment centers per state. And so you'll notice in the northeastern region, there is a significant amount more patients that are needing care than what we can provide given the state of our sickle cell disease treatment centers. Um, Disparities in sickle cell disease: 90% of sickle cell disease patients are African American and also can occur amongst other minority patient populations. But to put it in perspective, cystic fibrosis affects fewer than half the number of persons affected by sickle cell disease, yet it receives 3.5 times more funding from the NIH and 440 times more funding from the National Foundation. So when we think disparity, we're also thinking, we're thinking lack of research funding, lack of studies, and this can potentially attribute to um, the negative outcomes that we see in the sickle cell disease patient populations, right? So that's a high level, but from a more on ground level, frontline workforce, clinician hindrance to care is something that we have to consider. And this can be due to a lack of clinician knowledge, concerns about opioid use disorder, um, complex interactions between pain and other comorbid diseases, lack of effective or efficient evidence-based strategies for chronic management, and of course, racism and institutional barriers that are seen amongst clinicians throughout the country here. All things to consider in reference to the implicit bias and also um, the numerous studies that have been published with the depiction of pain tolerance amongst Black patients being the predominant patients that are affected by sickle cell disease here. And so I also pulled a couple editorials here where some quotes were provided by a doctor from Hopkins. My patients who are mothers, my patients who are lawyers, doctors, can all describe episodes of being treated like a drug addict, right? So these are real life situations. Specialists generally know what to do. The healthcare system just isn't doing it, is what she noted here. And this editorial that was published by the AAMC really described how they feel we are failing Black patients. And so I wanted to leave us with a thought provoking quote here, um, where racial and ethnic disparities in pain treatment are not intentional, right? We're not intentionally disregarding our patients, but instead, inequities are the product of complex influences, including implicit biases that providers don't even know they have. And so, this really leads me to my closing thoughts here, where next steps in bridging the healthcare gap for sickle cell disease. It includes more comprehensive treatment centers, implicit bias training for all healthcare institutions, and actually collecting data within our institutions on, to help direct what our efforts will be with that implicit bias or lack thereof within our institution. Removing individual discretion as much as possible to be able to treat individual patients effectively, and then continue to search for objective measures of pain. So, biomarker testing is one thing that was noted. In closing, the CDC Foundation has started a sickle cell data collection project. And really, what this is trying to do is prof- uh, establish a collaborative where data can be collected, efforts can be facilitated across the various states in our country, and states have to sign up for to be a part of this project. Currently, data is available in Georgia and California, and I'm also happy to share that Wisconsin, uh, data in Wisconsin is forthcoming as well amongst some of the other states. But if you're interested in learning more about this data collection project, you can visit the CDC website. And I'm happy to see more concerted efforts in this regard. So that is the conclusion of my grill presentation. And at this time, I'll open it up for any questions that we may have amongst the group.
Thanks, Kofi. This is Katie. Um, I can't let you get away without answering an infectious diseases question. Did you come across in your review about how we handle these patients in the hospital with acute chest syndrome?
That's no, I did not actually, but that's something I could follow up with you on.
Yeah, so this is something we commonly see on the medicine units where a lot of it is supportive care and oxygen related, really just vasoocclusion of the pulmonary vasculature, but part of the guidelines do recommend antibiotic therapy, which is generally kind of your standard CAP regimen, kind of like your Ceftriaxone plus atypical coverage. So that is something we commonly see from the inpatient side as well from a management perspective.
That's good to know. It's interesting, actually. Any other questions or comments from the group? All right. Well, hearing none, please make sure you all signed in with the crisis code, and I just want to thank everybody for coming and sticking it out through the last grill presentation of the semester, so you all can give, I said semester, excuse me, of the year. You all can give yourselves a hand, and thank you again.